Hello, everyone. I'm just going to let everyone join in here before we get started. Good evening, everyone. Just letting everyone come in here. We'll get started in a couple of minutes. Welcome. Feel free to introduce yourself, unmute, or pop it in the chat. We'd love to know where you're calling in or zooming in from and your role in long-term care. Hello, everyone. Just getting started. Please feel free to introduce yourself. Pop it in the chat. Let us know where you're calling in from or unmute.
Hey, my chat's disabled.
Oh, well, we'll get that sorted. Thank you for letting us know. All right, we're trying to get the chat sorted out here. Can everyone chat now? Hopefully. Welcome for those who are just joining. Feel free to introduce yourself. Okay, great. Thanks, Michelle. Now the chat's working. You can pop it in the chat or unmute yourself. We'll get started here in a moment.
Hi, Jess. Rod McFadden here.
Hi, Rod. Welcome. Thanks for coming.
Good evening. Hi, Jessica. I'm Denise from Victoria.
Hi, Denise. Welcome.
Thank you.
Can you hear me?
Yes.
Yeah, I'm Riley. I work at Dufferin Place in Nanaimo. And
Welcome.
Yeah.
Thanks for being here.
Yeah, thank you guys.
Okay, so it looks like we still have some people joining. I'll just do a quick intro and bio here, and then we will get started. So we have as much time with Erin as possible. So welcome, everyone. I am Jessica Swinwertson. I'm the LTCI operations lead from Victoria, South Island. I'm very privileged and happy to be speaking to you from the traditional and ancestral territories of the Sauk Nation. So I feel very lucky to work and live here. So a couple of housekeeping items first. Please keep yourself muted as background noise can amplify very quickly. There are CME credits available for this event. A member of the LTCI team will email you a certificate in the coming days, so watch out for that. At the end of the evening, we'll have an evaluation, so please take a few moments to participate. Your feedback is very important and helps us to shape future events. This event will be recorded and posted on our website, along with a copy of the slides from this evening. If you have questions throughout the evening, please feel free to unmute yourself and ask away. We like these events to be interactive. There will also be plenty of time left at the end for discussion. So we're aiming to have about 30 minutes at the end for Q&A, so have your questions ready. So I'd like to introduce our presenter for this evening and SWOC, Erin Ballard. Erin grew up on Vancouver Island and has been nursing since 2009. She began her career as an LPN in acute care, working with post-operative patients. She completed her degree in nursing in 2018 and continued to work in acute care in the areas of oncology and palliative care. Her interest and experience in wound care led her to complete a nursing specialty in 2021, and she is now a nurse specialized in wounds, ostomy, and continence. She moved from acute care to long-term care earlier this year and is now the NSWAC for 60 long-term care facilities on the island. So without further ado, please welcome Erin. Over to you.
Thanks, Jessica. And hi, everyone. Thank you so much for joining tonight. And I'll just share my screen and we'll get going because we've only got an hour and a half and we got lots to talk about. Okay. Okay, there we go. So as Jessica introduced me, I'm Erin, and I am your wound ostomy continence nurse for long-term care and Island Health. So just firstly, I have no conflict of interest to declare, and you can see there what I'm involved in my work life. And let's quickly just go over our agenda for tonight. We're gonna do an overview of skin and age-related skin changes. Then we'll talk about skincare for different conditions common in the geriatric population. Then we'll talk about some common wounds in long-term care. We'll go over a few products. And then lastly, we'll talk about the role of debridement. And then we should have a good amount of time for questions. And as Jessica said, if you have any questions along the way, unfortunately, I can't see the chat, but just unmute yourself and ask away. So let's start with talking about our skin. Let's talk about how our skin functions and why it's so important. So not only does it protect our insides from the outside, but it also performs sensory functions related to touch, pain, temperature. Our skin is made up of two layers, the dermis and the epidermis, and you can see those two layers represented in that overly colorful photo there. Keep in mind that the dermis is only 0.3 to 4 millimeters thick. So when we talk later about wounds and we talk about partial and full thickness wounds, any wound that extends beyond the dermis is a full thickness wound. So the dermis is made up of collagen and elastin fibers, and they provide structure to the skin, and they're essential for our wound healing. Blood is supplied to the skin through capillaries in the dermis. Between the dermis and the epidermis are finger-like projections, and they arise from both layers and they attach to the other layer. So this is what keeps the epidermis attached to the dermis instead of just shearing off. So there's a lot going on in that dermis layer in that photo there, as you can see, but you will notice how the top layer, the epidermis, is pretty empty. And that's because the epidermis does not have blood supplied to it, but it's fed by cell migration from the dermis. The epidermis is our waterproof layer that is made up of tightly woven cells that are constantly in a cycle of shedding dead skin cells and regenerating. So in the outermost layer of the epidermis, which is a stratum corneum, cells migrate upward through this layer and are shed every 14 days. However, for the older adult, this time frame has doubled because their cell migration and shedding has slowed by 50%. So as we know, skin is a renewable tissue. The ongoing regrowth of our skin cells is what keeps our skin looking healthy and young. But as we age, environmental and physiological factors have a detrimental impact on the reproduction of our skin cells. So as I mentioned, the cell turnover has doubled in time, but there are other age-related changes to our skin that have big impacts and explain why older skin needs specialized care and protection. So the physiological changes that we see are a decreased blood supply to the dermis, a thinning of the epidermis, which reduces that natural barrier function, a decreased number of immune modulating skin cells, which results in reduced immune response, a decreased tensile strength holding the dermis and the epidermis together, and that increases the risk of the epidermis shearing off, and also an increased skin pH, which leads to an increased bacterial growth on the skin. There's also environmental factors that damage the skin. And of course, the longer we live, the more we're exposed to these damaging factors. Photoaging is just a fancy term for sun damage, and we hear lots about how much the sun damages our skin over time. As well, cigarette smoking and air pollution damage the skin over time as well. So what can we do generally to protect the elderly and compromised skin from injury and breakdown? I think the best thing we can do is develop a skincare routine for all of our elderly residents that focuses on prevention, and not just for those who already have skin breakdown or wounds. So the first step in this routine is to cleanse the skin. And for cleansing, we use a pH balanced cleanser. So this means no soap for our elderly residents, because as we learn, the pH of the skin increases as we age. So if we use a pH balanced cleanser, this is going to help reduce that pH of the skin and reduce that bacterial growth on the skin. And also these cleansers are non-soap cleansers, so they prevent drying of the skin. When the skin is dry, it's just more susceptible to skin tears and other sort of friction injuries. If you're using a no rinse cleanser, these are pH balanced as well, but they, in addition to being pH balanced, they leave a filmy barrier on the skin that replaces that barrier that's lost through aging. So if you're using a no rinse cleanser, put this product directly on your cleansing cloth and then do not rinse it off. And I know it says right on the label not to rinse it off, but I know that there are those out there who do. And I know that because I used to be one of them. It just seems natural to want to rinse soap off after we clean, but this one is specifically created to not be rinsed off so that it leaves that barrier. As well, we want to ensure that we're using warm, not hot water, because hot water further dries out the skin. So then once cleansing is done, we move on to moisturizing. So we have several different creams on our shelves to choose from. The thing to remember when you're selecting the right cream is to remember what you want to do. So do you want to add moisture to dry skin, or do you want to protect the skin from moisture? And that's going to guide your choice. So if you want to add moisture, choose an unscented moisturizer. These work by attracting water to the skin. Moisturizers should be a part of standard skincare because they help prevent skin tears and friction injuries in any areas of dry skin, so legs and arms particularly. Alternately, if you want to protect the skin from moisture and prevent fluid loss from the skin, you want to choose a barrier cream such as a silicone or dimethicone. These work by filling in the gaps between the skin cells in the epidermis, and this way they prevent water loss from the skin. So basically use a moisturizer in the areas that are dry and then barriers in the areas that are moist or at risk of fluid loss. And applying your moisturizer while the skin is damp will make it more effective. So here we have a poll. If Sunita can launch that for me, which product would you use? And you see I've labeled where this is located. So go ahead and vote and then we'll talk about it. Oh, and I guess I can't see the answers, so we'll give it 30 seconds, and then if we've got enough people who have responded, Sunita, you can just choose when you want to end that poll. Okay, so can everyone see the results? We've got 12% who voted for unscented moisturizer. 53% of you said antifungal RX cream, prescription cream. 35% moisture wicking fabric. Nobody went for the PHMB gauze roll. Okay, well, let's talk about our options here. So firstly, what we've got is a location is under the breast. So what we've got here is intertriginous dermatitis, which is a rash in a skin fold due to moisture. So it's a moisture related skin damage. So our first option was a moisturizer. Now, we don't want to use a moisturizer in this area because it's already moist, and that's what's caused the damage here, the skin damage here is the moisture. So we're not going to use a moisturizer. Our next option was a antifungal prescription cream. Now, I know we use this a lot in our skin folds, but this, in looking at this picture right now, I'm not seeing any evidence of yeast overgrowth in this area. So we'd see probably more satellite lesions, sort of a white scaly yeast overgrowth on the area. So the choice that 35% of you said, which was a moisture wicking fabric, this would be my first choice as well, because let's have a look at moisture wicking fabrics and then we can talk about them. So moisture wicking fabrics are really my first choice when we're treating intertriginous dermatitis, because they're designed to move moisture away from the area and to provide antimicrobial, which is going to prevent growth or kill any bacteria that's living in that hot, moist environment. We have 2 wicking fabrics that are available to us. Depending on where you work, you may have seen one of them or both of them. One has silver in it and the other one has hydrogen peroxide. Both of these wicking fabrics are effective against Candida albicans, which is our most common infection in skin folds, and that is that fungal infection, that yeast overgrowth that you often see. So both of these fabrics are effective against that. So the reason I like these products is because they do 2 things. They address the cause of the dermatitis, and then they treat or prevent yeast growth. So for those of us who chose the prescription cream, that's not necessarily the wrong thing to do, but the wicking fabric is going to do both of the things that we want. It's going to remove the cause of what we're looking at here and also treat any bacteria that's in the skin fold as well. So I know that a lot of you have used these fabrics with varying success. So on the screen here is just a few tips to increase the chances of success with them. They cannot be used with any creams or powders. So if you do have a prescription for the antifungal cream, do not use these with that. It's sort of one or the other. The fabrics are good for 5 days. Both the silver and the hydrogen peroxide are good for 5 days. So what you want to do is every day take out that fabric, give your perform your skin hygiene, and then use that same cloth and replace it in the skin fold, because it will work for those 5 days. So this is a problem with these fabrics, is that they can be quite costly. But if you use them as they're intended, then they're actually not that bad. So they get kind of like mucky looking, which is why I think most people are inclined to throw them out and get a new piece, but they are effective for those 5 days. The only thing is that after 5 days, throw them out because they can't be washed and reused. And really the key to success with these is leaving that tail outside the skin fold, like you see in that photo there, because it's wicking the moisture away. So the moisture has to have somewhere to go. And really, we only want to be replacing before the 5 days if there's any urine, stool, or blood on the fabric, or if the skin's wet. So if you take that fabric out, and it's going to look gross and it's going to feel kind of gross, but as long as the skin in the skin in the skin fold is dry, then it's still working. So you can put it back in. Okay, let's talk about skincare for those residents with venous disease. For those with venous disease, we're going to use our barrier creams because, as we learned, they penetrate the outermost layer of the skin and they fill those gaps between the skin cells. And in this way, they prevent water loss from those edematous legs that we see. They also protect the skin from moisture damage caused by the fluid that leaks out onto the skin. So if your resident has developed a red, itchy, inflamed rash like the one that you see on your screen there, this is an acute venous dermatitis, and it needs to be treated with a group 3 or 4 topical corticosteroid for 1 to 2 weeks until it's clear. And then once it's resolved, you want to return to your daily skin hygiene and barrier cream for prevention. Daily skin hygiene for these folks is really important for preventing hyperkeratosis. So hyperkeratosis is that thick, scaly skin that we see on the lower leg. We see it in those with venous disease, but also lymphedema and those with diabetes sometimes. Those with diabetes, they have their neuropathic changes can cause that dry skin, which may progress to hyperkeratosis, particularly around the heel. And then for those with venous disease, they're at risk of hyperkeratosis as well because they've got reduced tissue oxygenation. And that leads to that buildup of the hyperkeratosis. So it's infrequent skin cleansing that leads to a buildup of skin scales and plaques. So regular skin cleansing to remove the loose tissue is going to prevent hyperkeratosis from forming or getting worse. And bacteria lives under those scaly patches. So for those with this condition, they're really at higher risk of getting an infection. And of course, we know that our diabetic residents are already immune compromised, so they're already at risk of infection. So for those with moderate to severe hyperkeratosis, removal really of the scales can only be done by a trained clinician with specialized skills. So prevention is really key with hyperkeratosis. So let's talk a little bit more about skincare for our diabetic residents. So that autonomic neuropathy can lead to decreased sweating and dry skin. And this can lead to cracks in the skin that can progress to wounds, and of course also lets bacteria in. So this is how dry skin can lead to wounds and wound infections so easily in our diabetic residents. Regular skincare, therefore, is very important for these residents. As well, diabetic residents should have a foot care nurse who can provide callus reduction and nail care. So callus builds up over areas of high pressure, giving us kind of a warning about an impending pressure injury. So this is why I recommend daily foot inspections for diabetic residents so that wounds can be caught before they start. As well, callus itself exerts pressure and it can create or exacerbate wounds. So if your resident has fissures or breaks in the skin on their feet, cover them with a simple dressing to prevent bacteria from getting in until they're able to be seen by the foot care nurse. If your resident is ambulatory, they should have good diabetic shoes, and they do need to wear them at all times, even when they're just getting up for a short walk to the bathroom. Shoes at all time is really important. And a favorite topic of mine, incontinence-associated dermatitis. So a recent journal article on incontinence-associated dermatitis reported that 4 days was the median amount of time for the onset of incontinence dermatitis. So it really doesn't take very long for skin breakdown related to incontinence to occur. So not only is incontinence-associated dermatitis linked to increased risk of pressure injury in the sacral region, but those with existing pressure injuries are more likely to develop incontinence dermatitis. So they're very closely linked, pressure injuries and continence management. So once again, prevention is our goal here, and standardizing our skincare routines for incontinent residents is going to greatly contribute to achieving this goal. We're going to use our no rinse pH balance cleansers, and then we're going to follow that up with a barrier cream, those dimethicone or silicone creams. And we're going to do this for all residents with incontinence with every pericare that's provided. So I say have those tubes of barrier cream in the room and use them, because the cost of using a barrier cream on everyone who's incontinent is much less than treating incontinence dermatitis and its complications, which are pain. Incontinence dermatitis is always painful. There's bacterial and fungal infections. And of course, there's just decreased quality of life for the resident. If your resident does develop incontinence dermatitis, there are several products that will help. So zinc paste is our first go-to when the skin is broken down. So as long as the skin is still intact, if it's reddened but intact, keep going with your barrier cream, your dimethicone or silicone. But as soon as the skin is broken down, then you want to move to your zinc paste. At the same time, as you've switched to a zinc paste, you want to discontinue use of tab briefs in bed and use the bed pads that are designed for continence containment instead. Because airflow is really important for healing. And then for really refractory incontinence dermatitis, I have had good success using one of those products on your screen there. They're a cyanoacrylate skin protectant. And these products are like a second skin or a lacquer that prevents stool and urine from making contact with the skin. And the great thing about these products is that they don't need to be removed. They just slough off the skin every 3 to 4 days. And then in that way, it just need to be a new layer needs to be reapplied every 3 or 4 days. And well, I'm not used to talking this much. So now we're going to move from skincare to wounds. I know you're all here to hear about wounds, so let's talk about wounds. So let's have a quick look at the wounds that you asked me to get involved with. These numbers are from mid-February when I began this job until about 2 weeks ago. That's where I got these stats from. And they're from the data that I keep on all the referrals that come to me from you all. So as you can see, pressure injuries are at the top of the list. And then skin tears, I thought, interestingly, were at the bottom of the list. But I was thinking that perhaps that is because skin tears can be easier ones to heal when they are. So I don't get referrals for those uncomplicated skin tears. But when they become complicated by comorbid conditions is when they come to me. And by that time, they've become either venous or arterial lower leg wounds. Because as we know, these wounds are often started as minor trauma, such as skin tears. And then the pie chart there on the screen tells you how many wounds I see that are healable wounds. And you can see that it's less than half. Now, some wounds surprise us all, and they heal despite my classification of them as maintenance wounds, and that's always a celebration to be had. But I think it's just good to remind ourselves that not all wounds are healable wounds. But let's talk about how, we'll do a quick review of how wounds heal. Although wound healing is delayed due to advanced age, age itself is not an independent factor that prevents wound healing. But comorbidities, medications, mobility challenges, and nutritional compromise do create roadblocks to wound healing. And these factors are obviously more prevalent in our population. So when a wound occurs, hemostasis is the first phase, and that's when clotting factors stop the bleeding. And then after that, the inflammatory phase begins when bacteria and debris in the wound are cleaned back, and the wound bed is prepared for the next phase, which is the proliferative phase. And then in that phase, collagen and blood vessels are replaced and granulation tissue begins forming on the wound bed. And when the wound closes, the remodeling phase begins as the new tissue continues to increase in strength. It will take months after the wound closes before the tissue is even at 2/3 the strength at what it was before the injury. And it will only ever get to a maximum of 80% as strong as it once was. So this is why we see a lot of re-injury in that same area, because that tissue is always going to be weaker than any other tissue. So let's talk about pressure injuries first, since they are the most common wound that you refer to me. Pressure injuries can develop quickly depending on the intensity of the pressure, and as quickly as within 3 hours. So as you can see, the cost of pressure injuries is significant, but more than the financial cost, the physical and emotional cost to the resident really cannot be overlooked. Pressure injuries decrease quality of life significantly for our residents, and in worst case scenarios, they can cause someone's death. So they really bear talking about this evening. So pressure injuries can occur from a combination of factors. Injury can be the result of bottom-up damage caused by pressure, shear, or both, or from top-down damage from friction, moisture, or both, or it can occur from a combination of all 4 of those factors. So we know pressure well. It's the prolonged or intense compression of the underlying tissues that occludes the smaller vessels and lymph vessels, causing tissue ischemia. Shear injury occurs when there's pressure plus movement, in which the bone stays in place and then the deeper tissues move across the bone. So this causes that deeper tissue injury. So think of a resident who is sitting up in bed at 45 degrees and then gradually just slides down the bed. That is a shear injury. Friction occurs from the movement of the skin across a surface with a light physical force, and this results in that superficial damage to the skin. So think of a resident who's boosted up in bed and their heels are dragged along the bed sheets. That would be a friction injury. And then moisture as well causes damage to the top layer of the skin, and it will exacerbate the damage from friction. Additionally, the tolerance of one's tissue for pressure and shear is also affected by nutrition and perfusion, microclimate, comorbid conditions, and the condition itself of the soft tissue. So, of course, as I'm a broken record, prevention is key here. We want to firstly recognize the risk in our residents, and we do this through our Braden risk assessment and our pressure injury rating scale that we do with our RI. So once we've assessed the risk, then we can put in our interventions to prevent pressure injuries. So we want to manage incontinence, as I talked about before. We want to reduce shearing by keeping the head of the bed less than 30 degrees if we can, as much as we can. We want to decrease the duration and the intensity of pressure. So we want to have our residents on a repositioning schedule and also have those support surfaces, those pressure reducing support surfaces as well. And if somebody's on a pressure reducing mattress or chair, they still require repositioning because those surfaces just can't prevent pressure injuries on their own. Now, heels are particularly prone to pressure injury for several reasons. There's a lack of soft tissue surrounding the heel bone, and also it's a small surface area for pressure to be redistributed. So with the absence of tissue and the small surface area, and also there's a low vascularity to that tissue that is present, add in neuropathic changes that cause decrease or absent sensation. We've got cognitive changes that may prevent our residents from being able to verbalize their pain, and then decreased ability to move their legs independently. And it's really no wonder we see so many heel pressure injuries in our work. And I certainly see a lot of heel pressure injuries. So the heel anatomy also means that injury can occur both supine or sideline. And because of this, pressure reducing support surfaces do not prevent heel injuries. And we need to offload the heel from the bed surface completely. So as you can see in that photo there, we want to float the heel off the bed. And as long as you can slide your hand between the bed and the heel, that's all you need. The leg doesn't need to be too high, or then you're risking hyperextending the leg. So although be mindful though, because floating the heel can create pressure elsewhere. And we've seen that when we see pressure injuries on the posterior lower leg. So of course, this is when we'll go to our OTs and ask for their expertise on the right way to offload. If the heels are not able to be floated off the bed surface, there is evidence that a multi-layer silicone foam dressing to the heels can help prevent injury by protecting against friction and shear. So the reason you want a silicone is so that the adhesive is gentle on the skin and it's multi-layered. It's not just a gauze dressing. There's foam dressings have several layers in them. So that's what helps protect that heel. And silicone dressings can be lifted up so that you can look at that heel every day, and then you can replace it. The tape is made so that you can lift and replace. So ask yourself when you're planning care for a resident, are they able to feel discomfort in their heel, and do they move their legs independently? And if you answer no to even one of those questions, then you really need to offload their heels immediately and then make that OT referral for the right offloading care plan. Okay, let's talk about skin tears. So as I said, decreased function of the sebaceous and sweat glands in our elderly population dries out the skin. And this is what makes it one of the things making it more susceptible to skin tears. Additionally, that thinning of the epidermal layer and the decreased tensile strength holding the dermis and the epidermis together really places our population at even higher risk of skin tears. There are some things that we can do to prevent skin tears. Again, a standardized skincare routine that includes using a moisturizer on the legs and the arms. There's also specialized garments out there for those who are at really high risk. So these are essentially padded sleeves for the legs and the arms. We can also do things to our routine that will help. So keeping our nails short and also avoiding wearing rings at work. Once a skin tear has occurred, you want to first control the bleeding. And then if your skin tear has a residual flap, like that photo on the top there on your screen at the top, then you want to reapproximate that skin flap with a moistened Q-tip. And then after that, you're going to choose a non-adherent dressing, ideally one without adhesive or a silicone adhesive, because that's the gentlest. But you want to choose a dressing that can stay in place at least 7 days. Because really, as I said there, we want to leave it be and let it heal. And for those with a residual flap, do as the photo on the bottom there guides you, and let your colleague know which way it should be removed so as not to pull that flap away. I did notice this picture is rather old, though. It's from 2009, and I wouldn't recommend this dressing for a skin tear. So it's only to illustrate marking that dressing with an arrow, but I would say foam dressings are our first choice when it comes to skin tears. So now we've got another poll. Maybe Sunita can launch our second poll for me. That would be lovely. And again, Sunita, I'll just let you decide when to cut her off. Okay. Oh, we've got quite a range of responses, which is great. So this photo actually represents the importance of, oh, now I can't advance my slides. All my buildup is lost. The importance of wound cleansing. So those photos actually, thank you. Those photos are just pre-cleansing and post-cleansing. So that's how important wound cleansing is in our wound care routine. So let's talk a little bit about wound cleansing. So newest evidence for best practice for cleansing hard to heal wounds, which is our chronic wounds. That's our new terminology for chronic wounds, is hard to heal wounds. So best practice is to use a surfactant-based cleanser. So these are your commercial wound cleansers. There are many of them out there, but they most often come in a spray bottle format. And the reason for that is that they provide the optimal PSI that will clean the wound but not damage the healthy tissue. So there are two types of bacteria that live in our hard to heal wounds. those that are free floating, and then those that are attached to the wound bed. The bacteria that attaches to the wound bed are what make up biofilm. And many of you may heard the term biofilm because it's more recently, it's become a factor that has been considered in hard to heal wound management. These bacteria grow and multiply underneath a protective gelatinous barrier. So these bacteria are so smart that they keep this kind of bubble over themselves. And this barrier protects them from antibiotics, antimicrobial dressings, and also mechanical debridement with traditional wound cleansers such as normal saline and sterile water. So biofilm lives in up to 80% of hard to heal wounds, and it prevents healing. It puts our wounds at risk of recurrent infection, and it most often is not visible to our eye. So the only way to combat biofilm is with surfactant cleansers. This is why you may have seen these products show up in your facilities in the last few years. And if you have them, use them, I would say, on any wound that has been present for longer than 2 weeks. As long as there's no non-visible wound bed, commercial wound cleansers are not appropriate for tunneling or sinuses. So that's when you want to go back to your normal saline. And also remember to clean your peri-wound well as well, because bacteria lives on the peri-wound skin and it can easily migrate into the wound. Ensure you're cleaning all of the dried exudate from the wound edges, because those wound edges need to be clean so that they can heal in as the wound heals from the bottom up. And if you have an antimicrobial cleanser available at your site, these can be an effective tool for those wounds with signs and symptoms of local infection. So with these antimicrobial cleansers, you do need at least a 5-minute soak to have any significant reduction on biofilm. Okay, and we'll talk about debridement. This is the last on our agenda, so just a couple more slides and then we'll have lots of time for questions. So debridement of our wounds is important because bacteria lives and grows in necrotic tissue, and wounds cannot heal if they're filled with necrotic tissue. There's several options for debridement, but there are 2 that we use most often in long-term care. The mechanical, which is the removal of necrotic tissue with good wound hygiene, with those surfactant cleansers or those antimicrobial cleansers. And then the second is autolytic, which is the breakdown and removal of necrotic tissue with a moist wound environment. We also have access to enzymatic debridement with Santal, but I don't use this one often, firstly, probably because it's a prescription product and I can't provide that, but more importantly, because it does not provide any antimicrobial properties. So if our wound is full of necrotic tissue, there's going to be a lot of bacteria living in there. And we can use Santal with only one antimicrobial dressing, and that's Hydroferroblu. All of the other antimicrobial dressings are not compatible with Santal. And I always think, why combine 2 products to achieve something that we can get in just one product? And I'll talk a little bit about which products on the next slide. And also we have sharp and surgical debridement that our residents have access to, but the resident does have to go to either a clinic or acute care to have this done. And as we know, this may not be within the goals of care for our residents. So we have more actually dressings for debridement, autolytic debridement, than just the 3 that you see on your screen here. I mean, just a foam dressing on its own will give you autolytic debridement because it's going to create a moist wound environment, and that can get rid of, a small amount of necrotic tissue. But when we're looking at more, my first choice is medical honey. So the failure of a hard to heal wound to progress has all been correlated with a higher pH level, and medical honey has a low pH, which helps us in our wound healing. It It also, the action of medical honey also forms hydrogen peroxide, which helps in debridement, which is what we're looking for here. So the medical honey, it pulls out a lot of fluid because it's an osmotic. So that supports that autolytic debridement. So it's got both an antimicrobial and the osmotic effect, as well as that low pH. So I've had a lot of success with medical honey on those wounds that we're looking to heal. And so we need to debride quite a large amount of necrotic tissue. Of course, it's not as time efficient as sharp or surgical debridement, but for those residents that don't have that within their goals of care, this is an excellent option. Then of course, we've got our gentian violet methylene blue, which we all know as hydropheric blue. I will use this product as a debrider. It's not as effective for large, heavy, necrotic burden. If we've got a wound with depth that's completely filled with thick adherent necrotic tissue, I would go with a honey. But for more shallower wounds that we're looking to get rid of some slough, hydropheric blue is a good option as well. And then we probably a lot of you have used iodosorb, which is another good debrider. It's a sustained release iodine. And the only thing about iodosorb is that it may dry out your wound a little bit, depending on how much exudate you've got, what type of wound it is. And also the iodine is held inside of starch beads. And these starch beads can get a little stuck on our wound bed when we go to do our wound care. So as well as giving a good irrigation, you want to give a good mechanical cleanse with gauze when you're using iodosorb. Okay, I said we would talk about, oh yeah, I guess that wasn't my last topic, because I did say we talk about products. So I've got a few more slides, but I think I still got 15 minutes to talk. So we'll quickly go through some dressing products, and then we'll have time for questions. So I'm going to start with primary dressing. So primary dressings are dressings that go directly against the wound. So firstly, our non-adherent contact layers. These are, we've got silver, silicone, petrolatum, chlorhexidine. There's lots of contact layers out there. These contact layers all have holes in them, and you can see one of them at the top of your screen there, and they're meant for exudate to move through them to a secondary dressing. So you always need a secondary dressing when you're using these. They're not great for highly exudating wounds with viscous exudate, because they just won't move freely through those holes. And because these dressings have holes, we want to make sure that we're not overlapping layers, because that's going to occlude those holes, and then your exudate's just going to get stuck on your wound and just pool there, which we don't want. And then next up, we have hydrophilic paste. This is a great dressing for shallow wounds in areas that are difficult to dress. It's going to protect your wound from the outside bacteria because it's an occlusive dressing. But because it's an occlusive dressing, make sure you're not using triad on wounds that are infected, because the bacteria is going to get trapped under there and grow quickly. This product can stay on for 5 to 7 days in between your wound care and wound reassessment. And then foam dressings. So you can see on that photo there, as I was talking about, like the multi-layer foam dressings, that's just sort of showing you the layers of the dressing there. Foam dressings are relatively new on the scene. I mean, I say relatively, they've been around for years, but they're designed to create the optimal wound environment, not dry, not wet, and the right temperature for wound healing. So there are many foam dressings out there, and they're not all alike. So just ensure that you're choosing the right one for your wound. There are the light options, which are for smaller exudate. There's the regular for higher exudate. There's ones with silicone tape. There's ones with non-silicone tape. And then there's ones without tape at all. So there's plenty out there. There's also ones with silver. So just think about what you want to do with your wound and then choose the right foam dressing. And then lastly, dry gauze dressings. You can see an example of that on the bottom of the screen. These are good for non-healing, low exudating wounds that we're drying out to stabilize for maintenance care. Otherwise, they have a strong adhesive and they that can cause skin tearing, and they don't create the right temperature for moist wound healing. So I really don't use these a lot for our healable wounds. For primary dressings, for wounds with more depth, we need to fill any wound depth that we see. So we've got a few options here. Hydrofiber dressings, that's the picture on the right. These are either plain or with silver. And these are designed to absorb exudate, and they can absorb high amounts of exudate, but what they do is they absorb it, they hold it away from the wound bed, and then they wick it upwards into your secondary dressing. So it's important to consider what you're putting on top of these hydrofibers, because if you put, say you put a foam light, so that that hydrofiber is transferring a lot of exudate up to that secondary dressing, and you're going to find you have to change that secondary dressing more than you want to. So think about how much exudate you've got and choose your cover dressing appropriately there. Then we've got our ribbon gauze, that's in the middle there. We've got PHMB or iodoform, which is iodine, if we want an antimicrobial, or we just got the plain. And then alginate is the one on your left. I don't use alginates a lot for wound packing because they tear apart quite easily, and they don't wick exudate away from the wound bed like the hydrofibers do. So if I have a choice between an alginate and a hydrofiber, I'm always going to go with a hydrofiber because they're going to prevent peri-wound maceration and they're going to prevent exudate from sitting on the wound bed. But what alginates are great for is for stopping any minor bleeds. So I definitely still keep them around. And then secondary dressings. These are most of the secondary dressings I use are super absorbents and foams. So we talked a little bit about foams, but super absorbent dressings are basically dressings that have the same technology as diapers do. So they have these polymer beads in them, and what they do is they absorb the exudate and they hold it away from the wound bed, and they absorb a large amount of exudate. So in this way, they're great for use, obviously, on highly exudating wounds. And the other good thing about these is that if you've got a contact layer that's good for 3 days or longer, you can change these secondary dressings without changing that primary dressing if you've got an extremely highly exudating wound. I do want to mention that ABD pads are, although they look like super absorbents, they actually aren't. They're not absorbent at all. So I don't ever recommend using ABD pads. And you do have, there's, again, plenty of super absorbent dressings out there. I've just included one on screen here because this is a nice cheap one. Cost-effective one that you can use hopefully you have at your facility, and they're much more effective than ABD pads. And then foams we talked about already, so we won't talk more about those. And if you want something more, if you've got a wound that you've been progressing for a while, it's been doing well, your resident is doing all the right things, you're doing all the right things, we're all doing all the right things, but for some reason, the wound is stalled and you want something to jumpstart the healing, we have what's called extracellular matrices. And again, as I say about everything, there's lots of them out there. You can see there, we've got pig, lamb, cow, half plant, lots of them out there. And what these are is that they provide that collagen scaffold on which granulation tissue can grow upon. These are not going to turn a non-healable wound into a healable wound. If you've got an arterial wound, it's not getting any blood flow. This is not going to make that wound into magically a healable wound. But it will move that wound out of that healable wound out of the inflammatory stage. And I have had good success. I had a pressure injury that I was following for, gosh, it must have been 5 months, and recurrent infections and you know, stopping and starting and plateauing, and it was almost healed. And we used an extracellular matrix. I thought, let's give this a try, because we've addressed the infection, we're offloading, continence containment is not an issue anymore. We're doing all the right things. And usually I check in on my wounds every 2 weeks, but 1 week later, I got an email from the nurse, and we both were celebrating the fact that 1 week later, just 1 week of using this extracellular matrix, the wound had closed. So sometimes they're the right choice, but I have said there that, you know, contact me if you're considering using one, because of course they're kind of costly. So you want to make sure that you're using them in the right wound. If you want to know how to make a referral for me, my referral forms are on the Island Health intranet, or with your director of care if you're from an affiliate site. And what I will do is sort of create a care plan, and then I'm going to check in on the wound about every 2 weeks until we meet our goal. And that's either we're going to heal that wound or we're going to maintain it in a stable state. And I do that virtually. I am set up with BC Virtual Visit if any facilities are using that, and or by email or by phone. Unfortunately, just because I'm regional, I can't come to the site. And just don't forget, I can help with ostomy, continence, catheter, and feeding tube issues as well. And oh, I put a little slide in here about local resources, since we are talking in the South Island. So we have a plastic urgent access clinic at the Jubilee, urgent vascular clinic, burn and wound clinic. For that, you need to get a plastics referral, the lower leg wound clinic, and then a great website, which is clip.ca. And this is where, if you want to know more about the dressing that you're using, then this website will have a product information sheet that'll tell you when and why to use it. And there's my email if you want to email me. And maybe I'll just flip through the references real quick, but I think the slides will be available if anyone wants to know. And I'm happy to take any questions.
Can you give us your email address again? I didn't get it.
Oh, I'm sorry. Can you repeat that question?
Sorry, I just didn't get the email address. It went too quickly.
Oh, I went too quick, didn't I? I'm sorry.
Okay.
Here, let's go back to that. Oh, gosh. There we go.
Thanks.
You're welcome. Yeah, nobody can write that quick, can they? Okay, well, maybe I can't see anyone, so I might stop sharing my screen now. And then, yeah,
Erin.
let me know if you've got any questions.
Hi, Erin. It's Rod McFadgen here.
Hi there.
I'm one of the attending docs at Glengarry, and I also attended an affiliate site. I got to tell you, first of all, that was a great presentation, and you have a lot of fans amongst the nursing staff at Glengarry, and I'm a fan. You've consulted on some of our most difficult patients, and we've had great results from your excellent advice. So thank you.
Thank you.
Couple of questions. One around the intertriginous lesions. So it's very common to run into a request for an antifungal cream in my binder, and you know, I'll try and track down a nurse, talk about it to see what has been used. In my experience, I don't often see much of the white, discharge you spoke of. I think probably as a function of how well cleaned these residents are.
Yeah.
So I'm again kind of relying on the presence of, whether they're satellite lesions. But yeah, I learned a ton today about the use of interdry, and I guess that would be one thing that might change my practice is is to sort of look at, ask specifically about whether it's been used. I shouldn't be using product names, but I think you know what I'm referring to.
Yeah, that's right. And that's the one that has silver. But like I said, there's another one as well. Those ones you'll see in our owned and operated, because that's the one that we have access to, is the one with silver, the one that you mentioned. There is another product out there with hydrogen peroxide for those of you at affiliate sites. But yeah, I like I said, I really like those wicking fabrics, because of course, you know, when we put a cream in there, it gets even more moist. And I have had really good success with these fabrics. And sometimes it's just a matter of keeping them in place. I mean, one tip that I got from someone was if somebody's got a intertrigo under the arm, that's a pretty tough place to keep a fabric in, because they're using their arm usually. So what we tried was cutting a hole in the fabric and then putting it on like a sleeve and then having it drape down. And then that way it stayed on quite nicely. So I find that was really a helpful tip, but I know using these fabrics can sometimes be a challenge. So that's why I try and, you know, give a few tips about, like, especially like when we take those fabrics out and we think, oh God, they're like wet and kind of yucky. But that means they're doing their job, and really making sure that we leave that tail outside so that the moisture has somewhere to go. So just making sure that fabric is not just in the skin fold and that's it, like 5 centimeters of tail.
At the risk of being a mic hog, can I ask another follow-up question? I'm sort of, I think, more quick to prescribe an antifungal cream in my insulin-dependent diabetic patients when they've established this. And I have seen some people use a combination of an antifungal with a low-potency steroid cream. Any comments on that from your experience, whether that's a reasonable or even risky combination to use in the presence of what's presumably just a fungal infection?
Right. Yeah. I think what I will do is move to that corticosteroid and antifungal once we've trialed the fabrics for 2 weeks and it hasn't worked. So if it's something that's refractory, then we can move to that. I do like to try the fabrics first, but if it's someone who's at really high risk, then I think moving to your antifungals right away is not a bad thing.
And I see that Michelle has a question in the chat about the best products for hypergranulation.
Oh yeah, okay. Oh, I don't see it, but yes, okay, hypergranulation, that's a good one. I know when I was doing this presentation, I actually had more slides and I thought, I can't tell them everything, but let's talk about hypergranulation, because hypergranulation occurs on our wounds. And this is that tissue that grows above the level of the skin. It's red, it bleeds easily. And this is caused by either infection, friction, or ongoing pressure, or of course, a combination of any of those things. So, and we also see this around tube sites, like feeding tube sites, because of that friction, or suprapubic catheter sites, because of that friction. If that tube isn't what's the word I'm looking for? Secured, then that tube moves in and out of that stoma, and that's what creates that hypergranulation. But for wounds, what I would be looking at is what's the cause, right? So do we have an infection? What other assessments are pointing towards an infection? So then correcting the cause. And then as far as treatment goes, what we want to do is usually what I'll start with is a foam dressing that exerts a little bit of gentle pressure on that wound bed. And that in combination with treating the cause can resolve the hypergranulation. If it doesn't, then our next step is to go to a corticosteroid.
Oh, okay.
Did that answer your question, Michelle? Perfect. Okay. Does anyone else have a a question? I know there's a couple in the chat here, so maybe, well, while you all are thinking of some more questions, Gloria's got 2. Okay, what's a recommendation for turning, repositioning on residents during the night with high risk pressure areas or existing pressure injuries? Well, first I'd ask what kind of pressure reducing surface they're on, bed surface, and where their pressure injury is. But after that, turning, repositioning every 2 hours, it's kind of a hard question, because I wouldn't want to be woken up every 2 hours by someone to be turned. On the other hand, I also wouldn't want a pressure injury. So what I used to do when I worked in acute care with my residents is ask them what schedule, and this, I mean, obviously you wouldn't have to do this every night, so it's just a conversation that you need to have with them once, but what schedule, when do you want me to come in and reposition you? And then I would, explain to them like, hey, every 2 hours is probably the recommended. If they're on a really great pressure reducing mattress, you could probably extend that to every 3 or 4 hours. But if they're not, then every 2 hours. And then, yeah, I would just talk to them and see if they're amenable to that. That would be my recommendation. And then Gloria's also asked about maggot debridement. I think it's still being used, but it's not something that we do in long-term care because we just don't use it enough. Gosh, yeah, like I can't see it being used outside of acute care, because the competency, like how would our staff have the competency to be able to do the maggot debridement in long-term care? I think it would be too difficult. So even in acute care, I think I only remember really doing it once, but it's great. It's a great therapy, but it's very specialized. So I can't see it being done in long-term care really ever. And then Denise asked, what do you recommend using instead of AVD pads? And so if you remember that slide, I had a picture, and what those are, I don't think this is even probably a product recommendation, but they're classic pads. And these are the ones that are cost effective. So if you work at a facility that stocks AVD pads as your super absorbent, if you could maybe have a conversation with whoever does the purchasing and say, hey, what about looking into getting classic pads? And I bet the cost is pretty similar because those things are cheap. And for most of our wounds, those classic pads, there are ones that are sterile, but there's also ones that are not sterile. And for most of our wounds, we're not going to need the ones that are sterile. So they're going to be even more cost effective. So that would be my recommendation instead of ABD is classic pads. Now there's also lots more super absorbent dressings out there, depending on what company you use, dressing wound care product company you use at your facility. But that would be my recommendation. Does someone have a question? I heard somebody unmute themselves, so. Yeah, okay, great, thanks Denise. Okay, and then Odette asked, wondering how to treat blisters. Yeah, so blisters are deep tissue injury, right? Our deep tissue pressure injury. That's when we're going to see those. Well, I mean, there's lots of other causes of blisters, but most of the time, like say we see a big fluid filled blister on somebody's heel, that's evidence of a deep tissue pressure injury. And so at this point, the injury has occurred. There's nothing we can do to undo that injury. But what we want to do is protect it from further injury. I would, when you've got that blister, I would cover it, yes, with a foam dressing until it opens up. Once it opens up, then we want to change that dressing. And Vanessa, I think that Jessica said that the PowerPoint is going to be available. I don't know where though. Jessica, can you speak to that? Oh, it'll be on your website. Perfect.
Yeah, I'll share the URL in the chat.
Okay, thank you. Thanks, everyone, for the questions. Does anyone else have any questions? I thought there'd be some.
I have a question.
Yeah.
I was just wondering when you could like use the Mepitel ones. Like, do those go over skin tears? Because someone was telling me that, and I just wasn't sure like when those are used best for.
Yeah, the Mepitel one. So what that one is a silicone contact layer. So there are other ones out there. But this is one example of a silicone contact layer. So this is a non-adherent, one of those non-adherent contact layers, you know, that have holes in them. So they can be used over skin tears, but then you're going to need something to go over top of that as well. So once again, I always think, well, why not just go with a silicone foam, right? Because then that's one dressing that you can just use over the skin tear that's going to absorb any exudate, but also have that silicone contact layer built into the dressing so it's gentlest on that skin. But I also have seen, what did I most recently use the silicone contact layer on? I had a resident who has non-healable wounds on his legs for various reasons that I won't get into, but with a large amount of exudate. And so but he also is on anticoagulants. He's got extremely friable skin. So what we did is use the silicone contact layer over over the wounds on his legs, and then put our super absorbent pads on top. So that way we can change those super absorbent pads PRN as we need to. And then those silicone contact layers are actually good for 14 days. Depending on what's going on, but you can leave them on for 14 days. And you can actually irrigate the wound through those, because they've got big enough holes that you can irrigate the wounds through those contact layers if you need to. So like this resident had kind of more thicker exudate. It was kind of getting stuck. But we tried lots of things. And so this is one that worked, that we could put that contact layer down, irrigate if that exudate was getting stuck, change the super absorbance as needed. So I guess now that I think about it, a lot of times when I use those silicone contact layers is for non-healable or palliative wounds where I want to keep something on the wound for as long as possible in a sort of more comfort care approach because they can stay on for 2 weeks. Skin tears, yeah, I mean, you can definitely use them for skin tears if you don't have an appropriate foam. I think that would be a good choice. What do you think, Riley?
Yeah,
Does that answer?
I just had one of my co-nurses recommend, there was just a small skin tear on someone's hand, and we put one of those down and then cut out a small piece of the inidine, like the little mesh, and put that over it, and then covered it with one of the Mucors. And I'm just like slowly learning like just what other people are doing and stuff, because I don't really have a huge like base like background on myself.
Yeah.
So I just like I've kind of been taking in what everyone else does, but I just kind of want to start my own practice and have my own opinions on what's best.
Yeah. And I would say for that resident, right? So we want to think about what we want to do with that skin tear. So it's on her hand. If we're looking at her wound and we think that we're seeing signs and symptoms of infection, then inidine is one antimicrobial layer that you could use. But if you don't see any signs and symptoms of infection, and it's not in an area of well, it depends on how much she washes her hand, but I was going to say it's not an area of high bacterial burden like, you know, our coccyx and sacral wounds are. Then I would go, so you want to choose one or the other, right? What do you want to do with the wound? If you want to prevent or treat infection, you're going to use your inidine. But if you just want something, and inidine is a non-adherent, right? So it's already a non-adherent. It's going to treat that infection that you're seeing. But if you're not seeing an infection, then you want to go with your silicone contact layer and forget the Inidine, because you don't want to put those together because they both have those holes, right? So if you put them together, it's going to prevent
yeah.
any exudate from moving through. And I
Mhm.
will say also about the you said you were covering it with Meepor. Now that's our gauze dressings, and as I said, they have a really strong adhesive. So, and they don't give our wounds that right temperature for wound healing. So I don't like them on wounds that we're looking to heal, which this one I think we are.
Yeah.
So so you've got 3 things there. I would just scrap those 3 and then use one, which is just a little silicone foam, if you have that at your facility. But I would say definitely you don't want to use 2 contact layers together, because they're going to prevent either of them from working.
Yeah,
Does that make sense?
yeah, that does. I work on a unit, we just started it, and there's about 8 residents, that are active users, and they're in and out of the facility all the time, and they just come back with a lot of skin tears from their wheelchairs and
Oh yeah.
things like that. And it's like super, super hard, and a lot of it is just prevention of infection the whole time,
Okay. Yeah.
because
Yeah.
and unfortunately with the dressings, they do need to be, that we can't leave them on for the 7 days that they should be, because they come back and they're dirty.
Right. Yeah.
So it's kind of like a tricky situation. It's not like a population that'll keep it clean, because we don't really have any way of stopping it.
I mean, I will say about those foam dressings, they are waterproof. So
Okay.
if they're going to keep that bacteria out, whereas of course those gauze dressings don't. So that makes sense, right? They come back, their dressing's dirty, you do have to clean it because that bacteria is going to get in. But the foam dressings, you know, I see what you mean though. They may come back with their dressing sort of half off, and then you have to, but if it's just a little bit dirty on the outside, that's okay, because it's preventing that bacteria from getting in, as long as it's still intact.
Yeah, and the foam is like the Meeplex, is that?
Yes, that's
Yeah.
one example of a foam, and that is a foam with a silicone border.
Okay, yeah, because like we have a lot of Meepors and Meeplexes, and then the ones that are just without the border, the straight ones.
Okay, yeah. And yeah, I was saying, you know, about skin tears, like it's nice if we avoid dressings with borders. You could use your foam, but I'm not sure that that would be appropriate for your residents, because then of course, then you have to wrap, right? You've got to wrap that dressing to keep it in place, and that can get messy. If somebody's really active, that's best for those residents that are not as active. But for your active residents, I would say, yeah, use your Mepilex. Yeah. And if you are concerned about infection, there are foam dressings that have silver in them, so you could use that.
Okay, cool. I also have another question, actually. So there is a resident of mine that has quite a huge growth on their hip that they decided not to get removed. And my best way of describing what it looks like would be like a piece of cauliflower cut in half that is just continuous fluid coming out of it. Every time we irrigate it, it's bleeding. So we actually use the, what's it called? The Trenex.
Oh, tranexamic acid?
Yeah. So we actually have to spray it with that. And I was just wondering what you think the best way for layering something on that would be, like what kind of mesh would be best to place on that underneath what we want it to pull through.
Right, yeah. And sorry, did you say this is on the person's neck?
Hip.
Oh, hip, sorry.
Yeah, it's
I don't know
this
where I got that
huge
from.
thing, and it's
okay.
Just it's unhealable. We're just maintaining.
Yeah.
And they get it changed daily, but there's so much fluid that comes out of it. And right now we're using the really, really big bordered meplexes. But
I think you'd have better success with, this is a chance for you to use that product that you want to use, the Mepitel one. So you could use your silicone contact layer over the wound, and then use your super absorbent over top. If you've got any bleeding, there is those calcium alginate dressings that you can use for minor bleeds. So what you do is you just put a little bit of that calcium alginate right on the area that's bleeding. You just leave it on there, and it can stay on until the next time you provide like full wound care. That will stop the bleeding. Although it sounds like you have tranexamic acid, which is working too. So so that's not the issue. The issue is the large amount of exudate, and this is a malignant wound, right? So you're right, it's not healable. And these wounds do produce a large amount of exudate. So that's when I really go to those super absorbent dressings. And so a Mepilex is not gonna, that foam dressing, even though it's a big one, it's still not gonna absorb as much as those super absorbents. So if you put your silicone contact layer over the wound, and then use the super absorbent on top, and then you can use maybe some mesh panties to keep that pad in place, or you could use some tape, whatever works best for the resident. And then that way you can just change those pads every couple days, hopefully, and then only really like perform wound care every, let's say, 7 days. It depends on is the wound odorous at all?
Well, this person was from the community actually, so it was quite bad when they got to us, and it was very odorous, like at the start of our like treatment and or maintaining, I guess. And now it's pretty, like, I'd say it's not as odorous as it started.
Okay.
Since there's daily wound care being done on it.
Right. Yeah.
So
And
I think we've been able to kind of pull some of the infection out, but it's still
and that, sorry.
Oh, that's okay. It's just quite the thing. I've never seen something like it. I was like, and no pain with it either. They're comfortable. It's just crazy. But sometimes when I see how saturated it is, it's just mind blowing how much fluid pulls out.
Yeah. And is this person ambulatory, or are they in bed?
Ambulatory.
Oh, okay. And so, I guess that's also another thing to consider, is how to keep that dressing on. But if you do want to get longer wear time out of the dressing, I would recommend using one of those super absorbents and seeing if it works.
Is it like the big blue ones? Is that usually, or do they come in white, or is it?
Yeah, there's so many different ones out there, but you can email me with whatever options you have, and we can choose the best ones. I mean, most of them all work the same, right? Depending on what you have at your facility, they all sort of work the same.
Yeah, I think that like a lot of things are going to be changing, because we actually are they're letting a nurse every 5 months do the SWAN program.
Oh, right. Okay. Yeah.
And I just applied for it, and I think like they just saw that there's a really big need for extra education, because right now we have the RNs juggling the wound care, but on top of everything else in the building, and it's just getting it's really overwhelming for everyone to focus on wounds and focus on everything else at the same time. We're needing like a team that can, or a couple people that can be specifically focusing on the wounds.
Yeah, absolutely.
And
well, that sounds good.
Yeah, and and now I'm getting really interested in all this stuff, because I think like too, if we're able to order stuff, I'm sure, but we just not a lot of people have learned about it.
Right. Yeah.
And products. So we use what we have because that's what we think's the best, but we're not educated on what could be better.
Well, and like I said, a great thing to do too, if you're thinking about using a dressing, is go on that Click website and look up the dressing and its product information sheet. Those are really, I know product information sheet doesn't sound very exciting, but they're actually really user friendly. They're just going to tell you like when to use it, when not to use it, and how to use it. How often do you change this dressing? Like really like good practical tips, not like what it's made. Well, it might be on there too, but I find them really good, just to have like, okay, I just want to know the facts. When do I use this and how often do I change it and what does it do? So I like those.
Yeah, I've run into a couple. The thing is, like, I know a lot of people will put, I've seen this a couple times and I was kind of confused about it, is putting the Inadine right on a wound, and then I go to take it off and the Inadine's just like the blood scabbed into it.
Oh, okay, yeah.
And it's stuck, and then I have to just soak it in a bunch of saline to get it removed. And I was just trying to like brainstorm ideas of how to avoid that whole thing.
Mm-hmm. And again, that
Because-
just goes back to our assessment, right? Like,
yeah,
so if this wound is too dry, like do we need a different dressing, right? Do we need to adjust that how often we're changing it? Or are we healing this wound and it's dry? A dry wound is not going to heal, in which case we need to add some moisture with a wound gel. So there's a lot of questions. Of course, there's always lots of questions whenever you all send me wound referrals. I think every single time I email you back with more questions. There's always lots of questions, but it's because we really need to know everything that's going on with that wound before we can find the right dressing. And the right dressing is really just the dressing that's going to achieve our goals. Like, I mean, there's so many dressings out there. It's not that there's one magic one out there that's going to do the right thing. It's just really knowing what you want to do with that wound. Is it too wet? Is it too dry? Is it infected? And then you just move from there, and then figure it out. And you just kind of learn your dressing products as you go, because it's pretty overwhelming, the amount of products that we have access to. And so I think that's why wound care gets overwhelming. It's like, well, I'm looking at a wall full of products and I don't know when to use this and when to use this. But I would go back and just ask yourself, like, what is the wound telling me, and what does the wound need? It sounds a little airy fairy, but anyways.
yeah.
And we've got a question from Connie that I better answer before we run out of time here. So thanks, Riley, and I'm glad that you applied for the SWAN program, which is for those of you who don't know, it's the wound ostomy continence program for LPNs and diploma nurses. Anyways, Connie had a question about what would you recommend for using on a pressure injury on an ear pinna? Okay, does that mean the outer ear? I'm going to assume it's the outer ear. I'm not very good with my ear anatomy, but this is a perfect time when we can use our triad or our hydrophilic paste, which I think the only hydrophilic paste we have access to is triad, because that otherwise I don't think you're going to keep a very dressing on there very well. So I would that would be my first choice for that. What do you think, Connie? Does that make sense? Do you have a particular wound you're thinking of? Well, that would be my go-to. Maybe Connie is. Oh no, I see her. She's still there. Does anyone else have any more questions before we're kind of running out of time? But does anyone else have any questions?
Looks like we've got two in the chat there. So we've got a question from Jenny. Coccyx wound is always a challenge to dress. DT fold and always brings being close to anus. There is always a spot that allows BM or urine to go under. What can you recommend?
Yeah, that's true. As long as the wound isn't infected, I would go with the hydrophilic paste again, because it's going to create that barrier that is not going to allow urine and stool to get in. So I don't know if you've had any success with that. That would be, as long as it's not a wound with depth, which those wounds usually aren't, then that's usually what I go to if we're having trouble keeping a dressing on, which of course we always are in that area. What else would I use if that didn't work? Gosh, I don't know. I can't think of anything in the moment. I'll put it on the back burner and see if anything comes forward. And sorry, what was the other question there, Jessica?
Yeah, can you see the chat there, Erin, at
Oh,
all?
sorry.
There's
Yeah,
one
I think I was just looking in the Q&A and I forgot.
Okay,
all
yeah,
about
there's
the
one
chat.
from, there's a couple in there now. So one from Rod McFadgen. Can you see that near the end?
Oh yeah, I'm a resident who has very edematous legs and are weeping so much despite aggressive diuresis that staff have resorted to using diapers. Yeah, well, that works. Would the high absorbency dressing work? Yeah, I mean, honestly, diapers are the exact same as those super absorbent dressings. So although super absorbent dressings would probably give the resident a bit more like dignity, but yeah, those super absorbents are exactly the same as diapers. So I would certainly try that. And if it's an owned and operated site, they have access to all of those. So they should be able to order in whatever they need, whether it be classic pads or another super absorbent dressing. When to use EPC. So EPC is that zinc paste that I was talking about in the incontinence associated dermatitis slide. So when somebody has, so that's when I use it, is for incontinence dermatitis. And as soon as that skin is broken down, so if you have any open areas to the incontinence dermatitis, then I'll switch from the dimethicone or silicone cream to the zinc paste. The thing to remember about using that zinc paste is that it's really thick and you don't need to remove it every time you give pericare. So I think that's where we kind of go wrong with the zinc paste, is that we're trying to scrub it off every time we give pericare, and we can leave it on for 3 days, much like the hydrophilic paste. We can wash the top of it if we need to, reapply another layer on top, and then only take it off every 3 days for a reassessment of the area. And how an easier way to take it off is by taking some of that no rinse foam cleanser that you have, putting a bunch of that on top of the paste, walking away, leaving it for a few minutes, and then coming back and taking it all off. And even if you've done that, you've soaked it, and you come back and you're taking it off and you can't get every little teeny tiny bit off, that's fine. Just don't scrub the area. And I think, hopefully a week or two of that is going to heal up your incontinence dermatitis, and then you can go back to using your barrier cream, your silicone, your dimethicone. And then Jasmine asked, we have a client who had an open wound due to a burn. She spilled tea and burned herself. GP ordered Fusidin cream TID. It's challenging because we have to change the dressing every time we apply. Yeah, the Fusidin cream. Any advice? Client doesn't like us removing the dressing and changing it. Yeah, because anytime you take the dressing off, especially a burn, it's going to create pain once it's open to the air. And also every time we take our dressings off, it decreases the temperature of our wounds, which sets our wound healing back hours. So, but of course, burns are at high risk of getting infection, which is probably why the Fusidin cream was ordered. But topical antibiotics are, evidence shows that they're not as effective as our topical antimicrobial dressings. So a standard when I worked in the burn clinic was a silver contact layer to burns, and then changing those dressings every 3 days. Do you have access to a silver contact layer in your facility, Jasmine, that you know of? And no, hey. Well, you can, we are RESP. Oh, respite? Is that what that means? Yeah, okay. Okay, let's see, what other topical, if we have, we do want a topical antimicrobial on burns because they're just at such high risk of getting infected, but I don't think that 3 times a day Fusidin is our best choice. So if you want to email me when you get back to work with the topical antimicrobials that you do have, we can choose one that's going to work best for that resident, I would say. Okay. And then I think that was it for the questions. Let me just scroll back. I think, yeah, okay. And then the Q&A, did I get all those? Okay. Well, does anyone have any more questions before we go and have some dinner?
Thank you very much, Erin, for speaking to us today. That was a wonderful presentation. Thank you so much.
Well, thanks for inviting me, and it was really nice to see you all, and email me if any questions come up later, and I'm happy to help. Thanks so much.
Fabulous. Have a great night, everyone. Thanks, Erin.